I want to move on now. We'll switch from to the Canadian point of view. I'm going to introduce Dr. Stephan Probst, who's the Chief of Nuclear Medicine at the Jewish General. Stephan has, in my mind, been the front line of this particular subject matter within Canada. He probably has the greatest experience. Certainly, he's been using the diagnostic tracer for quite a while. He'll tell us that. I don't know. Most of this comes from hearsay, and his very detailed biography, which is 2 lines, doesn't give me a whole lot of background to be able to. I know him reasonably well. I've met him over the years, but I know he's been doing diagnosis for quite a while, and also the therapeutic, and will bring a Canadian perspective to us and just how to get it going in our various centers. Stephan, I'll let you take the floor.
Thank you. Hi, everybody. So my name is Stephan. I work at the Jewish in Montreal, and to talk to you today about how I think about PSMA Theranostics. These are my disclosures of conflict of interest, and you'll notice that AAA Novartis is on this list, so that's probably relevant for this talk. So Theranostics is actually not new. Theranostics is a portmanteau. It's a combination word, of course, therapy and diagnosis. In nuclear medicine, it's come to mean the pairing of diagnostic and therapeutic radiopharmaceutical pairs, but it's not, of course, an exclusively nuclear medicine concept. Dr. Hertz, Saul Hertz, is probably the guy who came up with Theranostics, although his work predates the term. He was the guy who came up with iodine 123 and 131. So this is kind of the initial theranostic pair. Richard Baum, a physician in Germany that I'm sure most of you are familiar with, came up with a kind of elegant way of describing theranostics. He says, you treat what you see and you see what you treat. And I thought, well, that really makes sense, doesn't it? So theranostic pairs, there are many of them, but I give you some examples. And I give you an example in each of what I call pair classes. So pair class 0 is actually using the same identical molecule. So iodine 131, we do this at the Jewish, 3 millicuries is a diagnostic scan, and 30 millicuries or 100 millicuries is a therapy. And if you go to pair class 1, you could switch out for the isotopes, so I-131 versus I-123. Pair class 2 is when the not just the isotope changes, but the element changes. And then pair class 3 is when the entire molecule changes. So PSMA 11 and PSMA 617, although they share a pharmacophore, are actually very different, or not very different, but different molecules. The Vision PSMA Theranostic pair, this is PSMA 11 and PSMA 617, which I'm sure you're familiar with, share the pharmacophore, which is the business end of the molecule, interacts with PSMA. The PSMA 11 was the PET agent loaded with gallium-68, the therapeutic loaded with lutetium-177. But interestingly, you can absolutely load gallium-68 onto PSMA 617, and many people do. The PSMA scanning options, none of which are Health Canada approved, unfortunately, are listed here. DCF-PYL, PSMA 11 are the most common PET agents. PSMA 1007, and there's a number of other fluorinated PSMA molecules are in widespread use in different parts of the world. Let's not forget the gamma imaging agents, which I think we may need to leverage in certain parts of the world where PET cameras are not available or are not installed in order to get the therapy out to patients. So Theranostics first principles. When I think about Theranostics, what do I think of? The first thing I think about is uptake intensity, and that is the expression of the target high enough to allow therapeutic efficacy, or can I get enough beta particles into a lesion to make a difference? And the next thing I think about is concordance fraction. That is, does all of the patient's disease harbor the target? The definition of positive is largely imported in PSMA from the work that was done in the neuroendocrine space. And the neuroendocrine therapies for lutetium-based therapies for neuroendocrine cancer predate the PSMA therapies. And this is the famous Krenning score, which uses the liver as kind of a deciding factor. So anything higher, more intense than the liver was a Krenning 3 and a Krenning 4. And this was kind of where we drew the line between the patients that were likely to benefit or not likely to benefit from therapy. In the registrational NETTER-1 trial for neuroendocrine cancer, 90% of patients were Krenning 3 and Krenning 4. So that's kind of where the Vision authors, when they were designing the trial, were coming from. If you're a nuclear medicine doctor like myself, pre-Theranostics, you were reading diagnostic scans, you were used to thinking of a scan and looking at a lesion in terms of diagnostic positivity. Is this or is this not tumor. Is this or is this not prostate cancer? And when you read scans for theranostics, you have to put on a different mindset. So diagnostic positivity is not equal to theranostic positivity. And in this patient, with which I'm showing you the FDG and PYL scans that are done very short time apart, you'll have an example of each. So this lesion is diagnostically positive. I know that's prostate cancer. There's enough PSMA uptake that that's a prostate cancer nodal metastasis. I also have the FDG to help me right next door. This lesion here is theranostically positive. So this lesion, I could probably get enough beta particles in there to make a difference. If you want to be an evidence-based purist and not worry about all the details and the intricacies of theranostics, you could pretty much take a picture of this slide, apply it, and you will use the vision criteria. This was the authors of the vision study who published basically what how and why they decided to do the vision reads. So the vision reads were all central. That is, they didn't trust any local assessment of the scans. They were all sent to the central review. And this is how the central review was performed. Essentially, there was no SUVs. The first thing that happened was you assessed the MIP or the coronal images for a PSMA positive lesion, which was defined as greater than liver. So equal to liver didn't make it. If you had one lesion, you move on to the next step. If you had no positive lesions, that patient was out. The next thing you do is you look at the diagnostic imaging, contrast CT or MRI, and you identify all lymph nodes greater than 2.5 short and all parenchymal metastasis greater than 1 centimeter. The bone metastasis with a soft tissue component is a very rare phenomenon that I've seen maybe once. So solid organ mets greater than 1 and lymph nodes greater than 2.5 in short axis. And you have to make sure that each of those lesions is again PSMA positive by the same criteria, that is to say greater than liver. If you have one PSMA negative lesion, you were excluded. If you had no PSMA negative lesions, you were included. So super simple, and if you want to be an evidence-based purist, this is really all you need. Of course, there was some pragmatic components of the vision trial, and I think, at least my personal opinion is we can probably do better than this selection criteria. We probably know more now or are able to dive deeper into each patient than the vision authors allowed in the trial for pragmatic reasons. So the first thing that's important to note is that the liver SUV is a moving target. So the liver uptake changes with the burden of disease. And this is something that you'll see in clinical practice. As the disease burden increases, all the PSMA is sucked out of the bloodstream by the Mets, and the liver ends up with significantly less uptake. So this is an important consideration. Of course, the liver SUV also depends on the tracer. For those of you that have PSMA 1007, be very careful. I think most everybody who's in this space agrees that SUV is proportional to dose, and dose is proportional to tumor response. So I hope to convince you that SUV matters. In the therapy trial, which used a very different PSMA positivity criteria and strict FDG PET concordance testing in all patients, so this was a very strict entry point to even get into this trial. The subgroup analysis of this trial, depending on the whole body tumoral SUV mean, showed a progression-free survival that was roughly equivalent to cabazitaxel in the post-docetaxel space if your SUV mean was less than 10. If your SUV mean was 10 or more, those curves show a pretty clear separation. Again, in the therapy progression-free survival SUV subgroup analysis, I'm going to draw your attention to this bottom panel here. If you had a quote-unquote perfect patient, that is to say, 100% FDG PET concordance testing that was done with 100% concordance and a whole body SUV mean of greater than 10, 91% of those patients got a PSA 50, which is an extraordinary number. In the analysis, which was presented by Dr. Armstrong at ASCO in 2022, the same thing held true for the vision group. So the radiographic progression-free survival by SUV quartiles, again, if you're in the highest SUV quartile, which was SUV greater than 10, 10.2 here, the median RPFS 14.1 months, whereas in the lowest SUV quartile, 5.8 months. So that's a very significant difference. And the OS analysis, again by SUV quartiles, showed that if you had the highest SUV quartile, your median overall survival was 21 months. So these are remarkable numbers. You've all seen this chart, these curves before. I'm not going to get too much into them. This is the vision trial. RPFS, imaging-based progression-free survival versus overall survival. But when I look at these curves, the first thing that I think about is, did all the patients benefit equally? And can we do better than this vision criteria? The vision subgroup analysis offers a little bit of a hint, maybe possibly, that those with liver metastases perhaps didn't benefit quite as much as those without, although this is a very wide confidence interval. We don't have a lot of numbers here, but other than that, I don't think there's too much to be gleaned from this information. Having said that, this was published at ESMO 22 by Dr. Armstrong, and this is a vision overall survival by PSA decline at 12 weeks. So this is 12 weeks is right before you're about to give cycle 3, if I'm not mistaken. So 0 weeks is cycle 1, 6 weeks is cycle 2, 12 weeks is just when you're about to get cycle 3. You look at what kind of PSA decline, what kind of PSA response those patients got. And this is overall survival. The patients that had a 90% PSA response at just before you were about to give cycle 3 is the blue curve on the top, whereas those that had no decline is the blue curve at the bottom. So I thought it might be interesting to overlay the curves from the totality of both groups, and wow, that looks messy. Let's clean that up. Let's look just at these two curves. That is to say, the best standard of care arm, the patients that did not get PSMA 617, they got secondary hormonal manipulation and a bunch of other things that did not impact overall survival. So essentially the placebo group, and the PSMA 617 patients who did not have any PSA decline by 12 weeks. You'll notice that those patients actually did worse than the overall best standard of care arm. So this suggests to me that not everybody in the vision trial was benefiting equally. Another thing that I've talked to you about, and I'm going to dive a little bit into, is concordance fraction. Concordance fraction roughly for me is the disease volume, which is positive on the diagnostic, and we can define positive how we want to, but the disease volume that we decide is positive, theranostically positive, over the total disease volume. So how can we define the total disease volume? Can we use the diagnostic? Can we use PSMA PET to define the total disease volume? And if not, how should we define the total disease volume? I think everyone agrees you can't use the diagnostic to define the total disease volume. So how do we do it? 3 different ways have kind of emerged. The Germans' compassionate use programs used the low dose CT done with the PET CT. The vision trial used the contrast CT, although the bone scans were done, they were not used in concordance testing, as you saw. And the therapy trial used FDG PET concordance testing. If you do cross-trial comparison, which you're not supposed to do, but let's do it anyways, you'll notice that the exclusion rate in therapy was much higher than the exclusion rate in vision. The screen fail rate based on imaging and vision was 12 or 13%, whereas the exclusion rate in therapy was 28%. Having said that, the therapy patients got a much better PSA 50. 66% of those patients versus 46% in vision got a 50% reduction in their PSA. So more selective, exclude more patients, get better response. Makes complete sense. This is an example which was published in the European Urology Oncology, PSMA, FDG. You'll notice lots of FDG positive disease in the bone. And then if you do the subtraction, you'll notice that there's disease that you can target with PSMA, disease that you can target with PSMA. And this patient, if I had to evaluate this patient clinically for therapy, I would not treat this patient. Polyclonality is the enemy of PSMA radioligand therapy. If you looked at this PET scan, you might go, wow, there's a lot of disease here. It's definitely hotter than the liver. Let's go ahead and treat this patient. But let's dive in a little bit on the imaging. Uh-oh, there's a big lymph node here, no uptake. Let's get the FDG to confirm that that's active disease. It's active disease on the PSMA PET. And this patient, you can note lots of discordance, lots of disease. That disease is, you're not going to get any beta particles in there, and that disease is going to progress. And it's the most aggressive disease because it's the disease that's the most FDG positive. When you're using vision PSMA positivity criteria, the bone is a complete blind spot. So this is a nice example of that same feature of discordance. You can only evaluate discordance in bone when you're doing FDG PET. Look at this bone metastasis, PSMA negative, strongly FDG positive. There's no way you can tell based on the CT or even a bone scan which is which. So without FDG, the bone, the skeleton becomes a complete blind spot, and you'd never detect this. This becomes obviously a patient who's a suboptimal candidate for PSMA radioligand therapy. This is cool work actually led by Fred Pouliot, Quebec group, showing that polyclonality increases with lines of therapy. So this is the kind of thing that I think everyone kind of had a feeling that was going on. It's nice to have some hard numbers depending on the lines of systemic therapy post ADT, including or excluding docetaxel for hormone sensitive disease. You go from 11-18% patients with at least one discordant lesion, that's FDG plus PSMA minus, all the way to 72 and to between 72 and 75%. I don't know what's happening at the 3+ range there. Maybe that's just a statistical gap, but I think it's very, very clear that the more lines of therapy, the more you'll have discordance. And as I said, discordance is the enemy of radioligand therapy. So this makes moving radioligand therapy into earlier disease states all the more relevant. In the same study, the location of the metastatic disease had a strong impact on polyclonality, and the patients with visceral metastases, specifically liver, had significantly more significantly more patients had at least one FDG positive PSMA negative discordant lesion. This is a patient that's not my patient. It's a slide that I stole from Dr. Hoffman, where you do the analysis depending on the different trials and you come up with completely different answers. So based on the vision analysis this patient is in, if you look at that lymph node, well, yeah, it's a little bit hotter than the liver. And therapy had an SUV-wide study-wide SUV max greater than 20 criteria, so that would have been an X for therapy, but definitely in for vision. Personally, I look at this and I don't really want to treat this patient. Zoom in on this lymph node. Yeah, sure, there's a little SUV7 hiding in that lymph node, but there's a lot of SUV3 hiding in that lymph node. So your SUV mean is not going to be anywhere near where you want it to be to get the treatment effect that you want. One thing that I want to caution everyone is beware of evidence mix and match. Don't use the vision PSMA positive criteria to inform on a therapy type analysis. So therapy looked at post docetaxel versus cabazitaxel. So if you're deciding between, if you have a patient who's post dosi, you're thinking about giving cabaz versus giving 617, you're going to want to do FDG PET concordance testing and use the therapy entry criteria, not the vision entry criteria. So those are different patient populations, and you have to beware not to mix and match your evidence base. So the Theranostics questions, basically, these are the questions that I'm asking myself when I'm looking at a case. What is the study-wide SUV max? What is the interlesional heterogeneity? What is the SUV max of the prognosis driving disease? If you have liver disease, that's always the prognosis driving disease. So accepting that sometimes a small node that's discordant is probably okay, because that's not what's driving the prognosis. As soon as you have liver disease, that's really the only thing that matters. What's the concordance fraction? Which concordance test did I use? Am I using FDG? Am I using CT, MRI? And what is the intralesional heterogeneity, as I showed you before? These are the things that I think about. This is totally not evidence-based. This is just my kind of like answer to these questions, if you will. So the best patient for me, what is the best patient? Let's go through that. Study-wide SUV max greater than 75. No discordant disease. Strict FDG PET concordance testing. 100% concordance fraction, and no intralesional heterogeneity. That's the best patient. That's the one that I love to treat. And then the other side of the coin is the study-wide SUV max less than 5 with discordant disease in the liver, poor concordance fraction, severe intralesional heterogeneity. These are the patients that I don't treat. So I encourage you to stop asking, is the patient PSMA positive, but to get into the weeds, get into the details. What is the SUV? What is the concordance fraction, and so on. Whoop. I think it should be clear that nothing's black and white. Yes, vision, and yes, therapy had to draw the line somewhere, because in a trial you have to say the patient either qualifies or doesn't qualify for the trial. But I think the reality is that it's a spectrum, and there's no black and white. And I encourage you to think about things and look at the images carefully and really evaluate if you think this patient's going to benefit, because every patient is quite different. Actinium-225, very exciting, obviously. Alpha, people have been talking about it. So you'll notice that the patient has a phenomenal response in his disease, but he also has a pretty phenomenal response in his salivary glands, right? So irreversible destruction of the salivary glands, big problem with actinium-225. Different people have proposed different things, intraglandular botulinum toxin and monosodium glutamate IV. Unfortunately, this doesn't work. It decreases uptake in the tumor as well, and this doesn't work, it causes xerostomia. So you're causing the problem that you're trying to treat. So that's work to be done. One other thing I wanted to bring up is radium-223. I think radium-223 is an interesting story. There was a lot of excitement when it came on, and then the excitement kind of faded away. And although it's still in use, it's definitely, you know, there hasn't been a follow-up study that I know of since the ALSYMPCA registration trial. So it's like, what happened to radium-223? And I think one thing that happened to radium-223 is we didn't use it as a theranostic, and we didn't do concordance testing. And this is actually borne out by some evidence that I'm going to show you. Should we be doing concordance testing for radium-223? I think the answer is yes. So this was an interesting study from Germany where they used PSMA as a radium-223 concordance testing. And if you didn't do any concordance testing, 13% of those patients had a PSA response. Whereas if you did do concordance testing, 44% of those patients had a PSA response. So maybe the reason radium failed to really catch on and grow and grow in indications is maybe because we're using it wrong and using it in the wrong patients. So, interesting. I'm not going to go through this. There's a lot of information on this slide, but if you think of theranostics as a therapeutic and a diagnostic, there's actually probably a third part of that equation, which is the concordance testing, right? So lutetium PSMA 617, you have a diagnostic, the PSMA scan, but you also have a concordance test. So these are the theranostic triplets, if you want to think about it. You have the therapy, the diagnostic, and then the concordance test. Models of cooperation. So nuclear medicine, obviously a lot of nuclear medicine physicians in this room. What do you want to, how do you want your clinic to operate? Do you want to be an imaging and infusion center? You know, a rec comes in, a report comes out, and that's pretty much it. Do you want to be a medical oncologist? Do you want to see the patient, examine the patient, do the physical exam, the neuro exam, order the CBC, transfuse platelets, and you know, really get into the medical oncology component of these things? Or do you want to do the middle ground? So at the Jewish, we're strongly in the middle in terms of this. We definitely defer to our medical oncology colleagues for all that is transfusions and all that is ancillary imaging. But we do see the patients, we do talk to them, we do have a big role to play in their treatment, and so that's where we are. I don't think there's a right answer here. I think there's different strokes for different folks, and different models will work best in different places. Our therapy protocol, super briefly, is very simple. Patient presents at 1, by 1:30, they're out of the department. We push the dose over 1 minute. The patient leaves after 5 minutes of imaging, and we do the 5 minutes of observation, and we do the imaging the next morning. You can do the imaging the same day, and there might actually be advantages to doing the imaging the same day, but we do like to do the images. This is the DCF-PYL on a patient that we treated. You'll notice that his post-cycle 1 image looks very much like his DCF-PYL PET. So this is the poor man's PET scan. As cycle 2 and cycle 3 are given, you'll notice the PSA drops, the lesions melt away. Unfortunately, cycle 4, cycle 5, cycle 6, the disease comes back. And if I show you all these in one slide, you'll see how the PSA nadirs down to 4 and then comes back to 32 as those lesions come back. So this gentleman progressed with PSMA positive disease. Radium-223 and lutetium PSMA, very, very similar therapy protocols. You're pushing the dose over about a minute. Your in total department time is about 30 minutes. We give pre-meds for lutetium and radium. I don't think anyone's doing pre-meds, but bottom line is if you're doing radium-223, you can definitely do lutetium PSMA. When to stop, I think knowing when to stop is super important. These treatments work, but they don't work always and they don't work forever. So be very careful and be judicious about when you're gonna stop. Disease progression, toxicity, and 6 cycles. We were never able to get more than 6 cycles from Novartis given the trial. So disease progression for me is the 3 Ps, the patient, the pictures, and the PSA. So look at the patient, the clinical status, look at the pictures. We restage after every cycle with the lutetium images, but we also restage with CT chest, abdo-pelvis, and bone scan because patients can relapse with PSMA negative disease. So we fall back on conventional imaging because number 1, we don't have infinity access to PSMA PET, and number 2, because of this danger of relapsing with PSMA negative disease that you could miss on a PSA scan, on a PSMA PET. And the PSA, the trend is obviously very important, as I think I've shown you with that 12-week data from Vision. So in take-home messages, I think Theranostics in nuclear medicine is a growth story. I think we're going to hear about the future from my colleague about where the future might be heading. I think Theranostic principles are simple at first. If you take a broad overview, it's simple at first, but I think no two patients alike, and devil's in the details. So I hope I've encouraged you to really dive into to get into the weeds and really think about each patient as an individual and not just a flow chart. So thank you very much.